Okay, good afternoon, everyone. My name is Utsa Khatri. I'm an assistant professor of emergency medicine and one of the core faculty at the Institute for Health Equity Research. And thank you for joining our Health Equity Seminar Series. I'm very, very excited and honored to introduce our speaker today, who I've known for many years. I won't say how many. But she is just a phenomenal person, scholar, and physician. So we will be hearing from Dr. Tiffani Johnson. Born in New Jersey, Dr. Tiffani Johnson was raised by a single mother and her village of phenomenal Black women. Her lived experience played an influential role in her career trajectory, including an under-resourced urban public school education. Dr. Johnson earned her bachelor's degree from Xavier University of Louisiana and her medical degree from Rutgers Robert Wood Johnson Medical School. After residency at Children's National Medical Center, she completed fellowship in pediatric emergency medicine and earned her Master of Science from the University of Pittsburgh. She started her early career at Children's Hospital of Philadelphia, then relocated to the University of California, Davis in 2019, where she is a tenured associate professor of emergency medicine. Dr. Johnson is a nationally recognized thought leader on racism and its impact on child health, who is working to ensure all children achieve their greatest level of well-being. Her research examines root causes of disparities, including racism in healthcare and society. She has maintained a steady stream of extramural grant funding, currently contributing to multiple NIH R01s. She has the distinction of serving as the president-elect of the Academic Pediatric Association. Dr. Johnson has won numerous local and national awards for her leadership and scholarship. Dr. Johnson is an agitator and abolitionist working to dismantle structures of racism. She takes great pride in being the daughter of Kathleen Smallwood Johnson, the favorite sister of Catherine Sophia Bell, and the best auntie ever. She is a lover of Black coffee, Black culture, and Black people. Thank you so much for joining us, Dr. Johnson. I turn it over to you.
Thank you so much for having me, Utsa. It is such an honor also to see you transitioning from residency to a fabulous career that you're leading, and I'm honored to be here with you today. So I'm going to go ahead and share my screen and get started. All right. So today I'm going to be talking topic, Your Silence Will Not Protect You, shining the light of truth on racism in pediatrics, but recognizing that this is a diverse audience. I also talk more broadly about racism and medicine in general. So I don't take for granted that everyone on this Zoom today may be on different phases in your anti-racism journey. So I just want to spend a couple of minutes initially just doing some level, starting our discussion today with just a brief history of the origins of the construct of race. This was highlighted in a commentary in JAMA Pediatrics in 2021 titled Recalibrating the Use of Race in Medicine and Research. And they describe how race was first introduced to the curricula in 1790 by Dr. Benjamin Rush, who asserted that Blackness was a particular form of leprosy. So it's important to note it because Rush was considered by many to be the father of U.S. medicine, and he was also a signer of the Declaration of Independence. So although he was actually an abolitionist, given his power and his influence, it really should come as no surprise to see how his concepts of racial differences have become a part of the American belief system, particularly not in America worldwide, as well as within medicine. Then in the 1850s, you see slaves who are characterized as biologically appropriate phenotype for hard labor under trying conditions. And then in the 1870s, we saw the racial exclusion in general society that reinforced medical segregation as well. Another example includes research measuring skulls across different races, which concluded that African people had smaller brain volumes and were therefore less intelligent than Caucasians. So this serves to help dehumanize many people of African descent, arguing that each race was an entirely separate species. So this really helps to illustrate how medicine and pseudoscience really help to legitimize not only this problematic narrative of genetic differences, but one that of Black genetic inferiority that in part helped to serve as a justification to uphold slavery and white supremacy more broadly. And so although, we're looking at examples dating back to, the 15, 16, 17, and 1800s, here are some additional examples about how Black people have been dehumanized, not only historically, but also in modern times. So here are some images of our first president of the US and giving him ape-like features. And here's another example with everyone's favorite basketball player, LeBron James, also being depicted in a dehumanizing form. And when we think about these images of race and racism, they not only impact adult populations, but they also impact children. So this is actually from an advertisement in a popular brand maybe about a decade ago, where this little Black boy is depicted as the coolest monkey in the jungle. And so this is important because these images that we see in the media help to serve as primes that further reinforce the persistent and pervasive racial biases that we see in society. So another example of the historic context of racism in medicine is a physician who coined the term drapetomania, which was defined as a mental health disorder among enslaved Black people with symptoms including the urge to run away, to destroy property, disobey their masters, talk back to the enslavers, and refuse to work. And enslavers were encouraged to whip enslaved people and help, and as a way to keep them in a position of submission that they intended them to occupy as a form of prevention and therapy for this drapetomania. And so the history of racism in medicine also includes the exploitation of Black bodies in research. So beyond the well-known Tuskegee experiments, we also have Henrietta Lacks, whose cancer cells were taken and studied and propagated without her knowledge or consent. And the experimentation without consent on Black subjects also dates back to slavery times, including James Marion Sims, who was credited as the father of modern gynecology. So he perfected his surgical techniques by experimenting on enslaved women without the use of anesthesia, which he justified with claims that Black people didn't experience pain in the same way that white people did. And it's important to note that these false perceptions of Black pain persist even in modern times. So less than a decade ago, there was a study of Black medical students and residents, and they found that half of medical students and residents reported at least one false biological belief about differences between Black and white individuals, such as having less sensitive nerve endings, thicker skin, and stronger bones. And importantly, those who reported these false beliefs also rated Black patients' pain as lower and made less appropriate treatment recommendations for their pain. And beyond experimentation on Black women for gynecological research, we also saw the eugenics movement, which subsequently codified the disproportionate forced sterilization of Black women with claims of preventing the spread of violence, promiscuity, substance abuse, and intellectual inferiority. So this is just one example. This picture depicts two sisters, Minnie Lee Ralph and Mary Alice Ralph, who at the ages of 14 and 12 respectively were sterilized. And this was just 50 years ago in 1973. And it was done through the Montgomery, Alabama Community Action Program, a federally funded family planning clinic. So think about that, 1973. Although I'm far too young and fabulous to have been alive in 1973, many of you listening today, this is something that may have taken place in your lifetime. And so as we consider this historic context of race and racism, and I also just want to bring us up to date now to some of the modern context of how we still see race-based medicine that has continued to be practiced. So race-based medicine can be defined as the inappropriate use of race as a corrective, risk adjusting, or dichotomizing variable in algorithms, practice guidelines, or policies that influences clinical decision making. So we see many examples. The most well-known example is the use of EGFR, which is a race-adjusted correction for glomerular filtration rate. And the reason why this is important is because when we think about the disparities that we see, particularly when it comes to organ transplant, the fact that our Black patients had to have worse kidney function before they would even be considered for transplantation is one of the factors that may be contributing to this. So over the past few years, as we have seen a national reckoning around race and racism in general society, largely motivated by the murders of Ahmaud Arbery, George Floyd, Breonna Taylor, and others, we're also seeing a call to address racism in medicine, and many are eliminating some of these examples of medicine. But beyond We also see it in kidney stone calculators and calculators to determine who's higher risk for vaginal birth after cesarean section, cardiac surgery, and many other examples. I want to spend just a couple of minutes talking about this particular example as a pediatrician, because spirometry is, although hopefully most of my pediatric patients are having vaginal births after a C-section, many of them do have asthma and other pulmonary diseases, which require use of pulmonary function testing. Let's talk a little bit origins of race correction in spirometry. So this actually goes back to Thomas Jefferson, who wrote in 1781 in a treatise on notes Virginia about differences in the lung capacity between enslaved and white colonists. So he remarked on the dysfunction of the pulmonary apparatus in Black individuals, and that, quote, among the real distinctions which nature has made is a lack of lung capacity, unquote. So then we had the same Samuel Cartwright who wrote about drapetomania, who performed experiments using enslaved populations in his plantation as subjects. And he concluded and published that the lung capacity in Black individuals was 20% deficient. And he went on to theorize that because of their smaller lungs, it prevents them from inhaling air. And so forced labor was what he prescribed as a way to vitalize the blood and to correct this problem of their lung capacity. So this is another example where you see how pseudoscience not only served to reinforce the practice of slavery, but then it also became the foundation of race-based pulmonary function testing, even in our modern times. And as a pediatrician, I'll give another prominent example that we see in pediatric practice. We're seeing attention towards race-based medicine in pediatrics, is this now retired American Academy of Pediatrics UTI clinical practice guideline, which included as a risk factor for girls being back. So the article looking at the problematic use of race in pediatric textbooks, and some examples that they found were in 7 different categories. So one includes the use of race or ethnicity as a surrogate for social variables. There was conflation of terminology, conflating socially defined race with genetic ancestry is something we commonly see. Other examples include overgeneralizations or making claims based on limited data, using that lack political relevance or lacked inclusivity, using race in a way that promotes racial stereotypes, or made contradictory claims about race. And so I think that this is important, particularly as many of you on the call are likely academics who are writing articles, potentially writing book chapters and teaching. And so I would just challenge you all to examine some of the ways in which we have often implicitly just included race, and to be more thoughtful and more implicit about ways in which we are not using race as a social variable, but using a more race-conscious approach to our practice. And we, talked about some guidelines. This is also an example of the use of race in pediatric guidelines. So in this study, they examined 414 pediatric guidelines and found that 126 of them used race or ethnicity, and 76 of them used race in a problematic way that would have potentially negative effects on our patients and their outcomes. So as we think about the use of both the historic context of race and racism in medicine and the modern context, it's important to understand that many of these things are driving disparities that we see in pediatric healthcare, similar to disparities that have been identified in adult population. So this review article published in Pediatric Annals 1 or 2 years ago, I'll say that this is a great primer for those of you who may be newer on your anti-racism journey. And I also put this table here just to highlight that if you look for disparities, you're usually going to find them. So in almost every area of pediatrics that look for disparities, we identify disparities in care, including primary specialty care, ED care, inpatient hospital care, and surgical care as well. And this is another recently published within this past year in Lancet Pediatrics, where we describe the persistence of racial and ethnic disparities in pediatric healthcare and outcomes. And so when we think about all of these disparities that have been documented, it's important to really note the role that racism plays, whether it's racism at the structural level or whether it's personally mediated level, and the role of bias in our clinical decision making. So as we consider these disparities, it's also important to highlight that there's a growing body of literature that shows that Black patients in particular have improved health outcomes and less disparities when they're cared for by Black doctors. So in this first study that I cite here, published in 2020, they found that when Black newborns are cared for by Black physicians, there's a significant improvement in the Black-white infant mortality gap. I just want to pause there for a second. And I want you to take a moment and imagine if the opposite were true. Imagine if white infants had a higher mortality rate when they were cared for by Black physicians, but lower mortality when they were cared for by white physicians. And imagine what the response from our health systems would be in comparison to very little response that we've seen in the past 4 years since this article was published. A similar study looking at adult patient populations found that a greater Black primary care physician workforce representation was associated with higher life expectancy and was inversely associated with Black mortality and mortality rate disparities between Black and white adults. So while only allowing Black doctors to be cared for by Black patients to be cared for by Black doctors is neither feasible nor the only solution for addressing mortality rate disparities for Black infants and adults, I think that these studies do support the importance of efforts to diversify our healthcare workforce in order to better reflect the patient population that we care for. But despite the many known benefits of workforce diversity as a multi-pronged approach to addressing inequity outcomes, there are persistent underrepresentation of pediatric faculty in my field, similar to all of the other fields that I'm sure are represented on this call. So in this figure, we see that URM faculty are depicted in the blue bar in comparison to the US population depicted in the red bar, with significant underrepresentation for those who are Black, Hispanic, Native Hawaiian, Pacific Islander, as well as American Indian and Alaskan Native. And then when looking at these trends over time, we see that there is very stagnant growth in terms of underrepresented faculty, again, depicted here in blue in comparison to the growing diversity of the pediatric population depicted in red. And this is looking at data between 2000 and 2020. What was particularly interesting from this study was that when it comes to Black men in pediatrics, which some of us refer to as unicorns because they are such a rare sighting, the numbers are actually going down over time since the 1980s. And so let's take a look beyond the talk about some personal experiences. So I want you guys to or virtual hands if you show up to a shift for work and you see colleagues or trainees that come from a similar background as you. Do you ever take a picture to mark that moment in history? I see any virtual hands going up or thumbs up. So I included some of these pictures here to help demonstrate that for myself and most of my Black colleagues, whenever I go to work for a shift and there are more than two of us working at the same time, we almost always take a picture to commemorate it because it's one of the rarest of rare moments, like a total eclipse. But for the vast majority in academic pediatrics and medicine overall, showing up to work and having a team that looks like you is the norm, and it's something that you take for granted. And I would love to see more pictures of more Black girl magic and Black boy magic and physician populations that are better representative of our patient populations. But as we think about these issues of diversity in medicine, I would really be remiss if I didn't also highlight the concerning phenomenon of the attrition of underrepresented faculty, particularly Black women in medicine. So on the left, we have Dr. Vanessa Grubbs, who wrote in the New England Journal of Medicine piece, my pending exodus from academic medicine after 15 years is prompted by my belief that the institutional and systemic racism so obvious to me would never be fully acknowledged, much less addressed. This belief was formed after several experiences that left me, a Black woman, feeling stifled, unheard, validated, unsupported, and concerned for my health. Then to the far right, you have Dr. Uche Blackstock, who, if you guys haven't purchased her book yet, I urge you to do so and read and cite Black women. But she wrote in 2020, I made the difficult decision to leave my faculty position as an at an academic medical center after more than 9 years there because of a toxic and oppressive work environment that instilled in me fear of retaliation for being vocal about racism and sexism within the institution. And then in the center, I provided an example of pediatrics. And so although this hasn't been published, this is one of my colleagues, Dr. Adia Spinks Franklin, who gave me permission to share that she recently left Baylor Texas Children's because, quote, they value in RVUs over faculty and patients. I moved in with my father to be his full-time caretaker after he was diagnosed with Alzheimer's in 2020. I did full-time telehealth, exceeding RVU goals, gave more than 24 pediatric grand rounds presentations remotely, was appointed to be the American Board of Pediatrics Developmental Behavioral Pediatrics Sub-Board, gave multiple media interviews, wrote 3 chapters on racism and child development in health and textbooks, engaged in national work for the Academy of Pediatrics, published commentaries and papers, and that still wasn't enough. She was told that she would have to return to in-person clinic or she would face severe disciplinary consequences. So after 17 years of service, feeling undervalued, underestimated, and marginalized, she chose herself and her family and left academic medicine. And I know that this is something that at least 7 times a day I think about doing. And I'm sure it's an experience that probably resonates with you all as well. So as we reflect on the race and racism that exists and is baked into medicine overall, the disparities that exist in medicine and pediatrics, and the underrepresentation of faculty in our field, I think it's important to spend a few minutes just talking about experiences that represented faculty have in medicine that might be driving some of this attrition. So why are you so angry? I wish I could see the audience now to see if there are any Black women on this Zoom who have been called angry in medicine before. And I could spend the next 3 days probably sharing with you some of my negative and honestly traumatizing experiences. But for the sake of time, I'm going to leave it to 2. So the first story I'll share happened a couple of years ago while I was still an assistant professor, when I had a white female colleague who was in an executive leadership role in one of my professional networks who asked me to write an apology email on behalf of the misbehaviors of a white male colleague on a race-related topic. So this misbehavior took place in an event that she organized, and I felt that if the white male responsible for the behavior apologize, and it was up to her as the leader to try to repair the harm that was done. She declined to write the apology I declined to write her apology email for her. And I calmly but very directly explained to her why it was an inappropriate request and why it was not my responsibility to apologize for white men. But displeased with my response, she told me that she felt attacked by me and that I sounded very angry. So I'll summarize by saying that as the discussion continued, after she poked and prodded and provoked, I actually did in fact become angry. And suffice it to say, I was able to very clearly demonstrate to her the difference between me being direct and me being angry, so she wouldn't have to confuse the two in the future. But this wasn't surprising to me, because I've had multiple experiences when confronted with race and racism where I'm met with tears of white fragility. This is another brief example. This anecdote is a story that I shared in a commentary in Pediatrics about an experience in a private directed message group for one of my professional networks, where a colleague actually posted a racist meme to this group. And so my initial response to that posting was, I took a screenshot, I called out the offensive content, and I delicately cautioned to be careful what you post, and I removed it from the chat. But in the next few days, I saw how the issue was being poorly handled, and I was really disappointed in myself. I allowed fear to dilute my response and what I actually wanted to in response to the post. And I was, afraid about expressing myself and how it might impact me professionally as an academic pediatrician who was Black and a woman and was still pre-tenure at the time. I was afraid of, again, being dismissed as being the angry Black woman who is overly afraid. I was afraid because I had already been admonished for being too critical towards good people that are novices and need to have a safe space so that they can learn about racism. But as I grew increasingly frustrated, because although so much is done to protect white fragility and to provide a safe space to my white colleagues to make mistakes as they navigate racial issues, I'm often left in fear wondering who is protecting me and where my safe space is. And so this is an example of, how I decided your silence will not protect you. It did not protect me from harm in this incident. And it was time for me to speak out and be more vocal about some of these experiences. But beyond these just personal anecdotes from me personally, this is another example of experiences of faculty in pediatric emergency medicine published in 2020. And one of the things that was really interesting to me was that this, being mischaracterized as the angry Black woman was one of the common themes that came up. They also were reports of feeling like they're carrying the weight of their race on their shoulders, and that because there are so few of them in the clinical space, that they have to represent all of Black people in society and in America, feeling like they can't show up to work as their authentic selves and the need to wear a mask. But one thing that was particularly noteworthy to me was some of the mental health consequences of these negative experiences. So one participant noted, it draws your attention away from other things that you need to do, even like sleep. And it would make me very nervous. There was a time where I just felt so constrained walking into the ED. My stomach would be in knots. Another reported, the number of times that I just spent in tears where my words were misinterpreted or just grudges being held against you, that kind of stuff. And again, just like you were saying, seeing other people could do the exact same thing and get none of the flack for it, that's just very psychically disturbing. And so these are just some examples that are part of a growing body of evidence of challenges that are experienced by those who are underrepresented in medicine. And so there have been lots of reports on how those of us who are underrepresented, we face many barriers that impact our experiences and our success. So these barriers include things like the minority tax, which has been well described, where those who are underrepresented have differential expectations for service, which then impacts their ability to do the other things that they actually get promoted for, particularly those who are on research tracks. But what is less well known or has been less described is the gratitude tax or the loyalty tax. So this is referred to as an expectation that underrepresented faculty may forego promotion or advancement at other institutions out of a sense of obligation to their current institution, and that they should be grateful for all the institution has done for them. And I know that I have also personally experienced this, where when questioning leaders around stances on race and racism, I have actually explicitly been told, "How dare you question me after all that I've done for you?" Another experience that we know is acknowledging distance travel. So recognizing that in comparison to faculty who are overrepresented in medicine, those of us who are underrepresented often face great barriers in both personal and professional lives in order to be able to move up in the academic ranks. And then we also have power distance, which is characterized as the hierarchical relationship in which a person who has lower perceived power defers to the person with higher perceived power. So at the level of faculty, this may result in differences in negotiating for salaries and resources and opportunities. Additionally, many faculty have described the imposter syndrome, which I know is well known, I'm sure, to everyone on this call, where individuals may doubt their skills, their talents, or their accomplishments, and have persistent internalized fears of being exposed as a fraud. But I'll make a note that for many of us who are underrepresented in medicine, this isn't just an internal struggle, but it's often a message that's received explicitly when we're marginalized in academic medicine. Others have also described many of the other challenges experienced by underrepresented faculty in every area for which we're evaluated. So when it comes to teaching, we know that women and those of us who are minoritized from racial and ethnic groups receive lower student evaluations in comparison to white men. When it comes to research, there are well-documented disparities in NIH funding as well as citations. When it comes to service, we've already discussed the minority or diversity tax. And when it comes to salary, there's also data that shows that Black and Hispanic faculty in pediatrics have lower salaries in comparison to their white counterparts. And I'm sure this is true for many of the other specialties represented here today as well. We also experience epistemic exclusion, where marginalized groups are devalued as scholars within academia, as well as gatekeeping, which really narrowly defines meritorious, determining who enters the field, who gets published, who gets funded, and what leadership opportunities are available. So based on all of these experiences, I have a very unpopular opinion that I present in these grand rounds and in these presentations. And that opinion is that academic medicine and the broader medical industrial complex overall is trash. So for those of us who are stand outside of the circle of society's definition of acceptable women, for those of us who've been forged in the crucibles of difference, those of us who are insert whatever your marginalized and minoritized identity group is, we know that survival isn't an academic skill. It's learning how to take our differences and make them strengths. For the master's tools will never dismantle the master's house. They may allow us to temporarily beat him at his own game, but they will never enable us to bring about genuine change. And this is from one of my favorite scholars, Audre Lorde. And so the question is, how do we do that, right? So how do we take our differences that make us so valuable and add so much richness to the clinical and academic environment and leverage them as our strengths instead of the way that they're perceived by others as weakness? And instead of simply relying on tools like grants and publications and honors and teaching evaluation to try to impact our patient populations that we care about so much and impact our communities and impact the world, instead of relying on being excellent according to these very narrowly defined standards of excellence and trying to be the model minority and respectable Negro, instead of struggling to temporarily beat a system that's so deeply rooted in white supremacy at its own game, how can we better access other tools in our armory to bring about genuine change? Because the master's tools will never dismantle the master's house. And so I'm going to share with you guys in the last 10 minutes before we open up for some Q&A. What are some strategies that I use for survival when I feel like I can't keep my head above water? And I love this picture of me, not because I like exposing my midriff to people in academic meetings, but to show that when we can't keep our head above water, it's mostly because there's actually somebody putting a stopper in the bottle to keep us from putting our head above water. And so that's important to note. And so most of my strategies center around self-care. And again, back to Audre Lorde, one of my favorites, she notes that caring for myself is not indulgence, it's self-preservation. And that is an act of political warfare. I've been a little frustrated recently because I feel like, especially in this post-pandemic era that we're living in, self-care has been colonized a bit, so that white women can feel good about going to the spa and taking bubble baths and getting massages and pedicures. And although I love doing all of those things, I think it's really important to note that particularly for those of us who are underrepresented in medicine and who are being oppressed and traumatized by these systems, we really need to go below the surface and do some deeper level care. So that includes things like trauma healing, inner child healing, crying and feeling emotions and being embodied, nourishing your body, community care, having difficult conversations, speaking out against injustice, purging negativity, setting boundaries, and acts of resistance. So I'm going to talk a little bit about how I am actively trying to do some of these things, although it is a daily struggle. So resistance is one of my favorite, but perhaps most challenging form of self-care. But I like to remind myself that there's such a long and rich history of Black folks in America resisting oppression and its various forms, and that really helps to encourage me. So resistance dates back to slave revolts in the 1800s, to Harriet Tubman, who I have her picture sitting up here in my office in the Underground Railroad, to Ida B. Wells and her anti-lynching crusade, to sit-ins and boycotts and protests during the Civil Rights Movement. And as I present to you guys from California, where the Capitol is just a couple of blocks away from me, thinking about the Black Panther Party, whose survival programs help provide food and education and legal aid, clothing and transportation and healthcare to low-income Black communities, while also challenging anti-Black police violence, even to the more recent protests in response to police killings of unarmed Black men, women, transgender and gender nonconforming people and children, and the ongoing protests that we have seen from in many college campuses across the U.S. Related to anti-Palestinian racism as well. And so turning to Ida B. Wells, we know that the way to right wrongs is to turn a light of truth upon them. And then I also often turn to Angela Davis, who reminds me that I can no longer accept the things that I cannot change, but it's time for me to change the things that I cannot accept. So when I think about wellness for me, it also includes speaking out against injustice and taking action to try to make an impact on changing policies, practices, and structures of oppression that uphold racism and white supremacy. So I want to just spend a couple of minutes talking about some of the research that I have done that helps me to focus on speaking out against these injustices. And so I really approach my career in medicine in three different phases, with phase one focused on identifying disparities, phase two focusing on understanding some of the root cause of those disparities, particularly in pediatrics. And then now I'm in a phase where I'm working on trying to reduce those disparities. So just to share with you quickly some of the work that I've done on identifying disparities. I've used research from national data sets. So this is data from the National Hospital Ambulatory Medical Care Survey, which was my fellowship project, looking at the association of race and ethnicity with the management of abdominal pain in the emergency department. Not surprisingly, we found that Black children are significantly less likely to receive analgesics for pain overall, as well as less likely to receive narcotic analgesics in comparison to their white counterparts. I've also, beyond some of those national data sets, focused locally to look at disparities in quality improvement. So if any of you on this call are engaged in QI work, you will know that when we think about QI work, we want to provide care that's safe, timely, efficient, effective, patient-centered, but also equitable. However, equity has often been neglected when it comes to our patient safety and quality improvement efforts. And so have been doing some work related to not only identifying what these inequities are, but then also how do we develop our QI initiatives to focus on making sure that we are centering the margins in the work that we're doing. And then I've also been doing some work with PCARN, which is the Pediatric Emergency Care Applied Research Network, to identify disparities. So even among these top pediatric EDs in the country, we see that inequities still exist. And so some of this early work shining the light of truth on these problems has now led to a disparities working group in PCARN. And the vision is that PCARN will be a leader in advancing health equity and workforce diversity through rigorous, high priority, multi-pronged institutional research focused on reducing unavoidable disparities and ensuring that all children can achieve their fullest level of child health. And so over the past couple of years, some of the work that this working group has done includes developing priorities for disparities and pediatric emergency care research agenda. We've also identified a set of core data elements, recognizing that sometimes these studies were later on down the line, trying to retrospectively look to see if there were inequities in care, but weren't collecting the appropriate variables needed to do it in a very rigorous way. And so we're trying to challenge the network that every study that comes through should really be collecting this data in a high quality way so that we can investigate not only inequities, but make sure that our interventions are impacting our most vulnerable patient population. And we've also done some work recently revising the evaluation forms that they use for protocols that come through the network to assess how they're considering the equitable inclusion of populations who are underrepresented and understudied, and generating knowledge about disparities that may be influenced by social determinants of health. So beyond identifying disparities that exist, which has been kind of foundational, particularly in pediatrics, because pediatricians like to think like, oh no, like that happens in the adult populations, but not with us. But now doing also work on trying to understand some of those root causes. And a lot of this work in my early career focused on looking at implicit bias in pediatric healthcare. In this first study, we use the implicit association test, and here we have the race IAT. I'm sure many of you guys are familiar with the IAT, but a quick primer. It includes pictures of Black faces and white faces and words that represent good or bad. And there are several blocks of trials. So in this block, when a Black face comes up, you'll link it with Black or good. When a white face comes up, you would link it with white or bad. If joy came up, you would link it with Black or good. If terrible came up, you would link it with white or bad. And what they do is they look at the number of errors that you make during the sorting, and they also look at your response latency time. So if it's easier for you to do a more stereotypical association of white or good, Black or bad, but it's harder for you to do this counter stereotypical association of white or bad, Black or good, then you have an implicit pro-white anti-Black bias. So I did some research in the pediatric ED to look at not only the presence of implicit bias, but really to look at how our cognitive load might impact that bias. So this was a repeated measure study where residents who were working in the ED, so this included pediatric residents, general EM residents, and then a smattering of psych, internal medicine, anesthesia residents that rotate through the pediatric ED that were given an IAT before and after their shift. And what we found was that among participants who were taking care of more patients during their shift, they had an increase in their IAT score comparing their before shift to after shift, with a mean increase of 0.17 that was statistically significant. We also, beyond just looking at how many patients they took care of, we looked at when the ED was more overcrowded through standardized NEDOC score, emergency department overcrowding score. And again, we found that when the ED was busy, when it was more overcrowded, when you're making more decisions, there was more bias at the end of the shift in comparison to the beginning of the shift. So I think that this is important for us to note that how do we encourage our residents and our trainees to take care of themselves and to take care of their bodies and create systems to help reduce some of this cognitive load, which may be able to reduce our bias. In this understanding disparities work, I also wanted to look at disparities towards adults versus children. And that's because when you look at this IAT, it has these pictures of these very scary looking Black adults and these very scary looking white adults. Like if any of them showed up at my door, I would not answer it, regardless of what their race is. But as pediatricians, we take care of super cute kids. So there's actually this IAT that was developed to give to children to see when children develop their bias. But I gave this IAT to our residents working in the ED to see if we have less bias towards these super cute kids in comparison to adults. And unfortunately, my hypothesis that everybody loves brown babies was wrong. So we found that although 85% of our participants had bias against Black adults, 91% of our participants actually had bias against Black children with no significant difference in the IAT scores. And interestingly, we also found that the IAT scores didn't vary by resident demographic characteristics. So even our pediatric residents who choose to take care of children and presumably love taking care of children, they had just as much bias against Black children as our residents from other specialties did. And we also didn't see any differences based on gender. And so this work is contributing to a growing body of literature looking at implicit racial and ethnic bias in healthcare that is impacting our patient population. And as this research on implicit bias in healthcare continues to grow, I think it's important to highlight that the associations that one holds towards different groups of people, they don't exist simply because of in-group or out-group preferences, but instead they're really rooted in this history that I've shared with you in the beginning of the talk on policies and practices that are reinforced through priming and association. So therefore, any discussion of implicit bias that we have really needs to be anchored in an understanding of the ways in which these biases were strategically cultivated through white supremacy and continue to be reinforced through structural racism over time. As a pediatrician, my work over the past few years has also really tried to highlight beyond just these interpersonal biases, really the role of structural racism on child and adolescent health, recognizing that racism impacts where children live, it impacts where they learn, and impacts what they have, including access to safe playgrounds and nutritious foods and economic opportunities, and it also impacts how their rights are executed. All right, so I'm gonna fast forward just a little bit because we lost a little bit of time because the devil is a liar and my internet connection got taken away. And I want to spend, you guys can Google me and read more about my research, but I do want to spend a little bit more time talking about how we focus on this self-care and this work to help us in everything that we do. So I think for me, other things that I do, in addition to using my research as a tool to shine light on racism, focusing on wellness beyond pedicures and eating healthy, nutritious foods that are going to fuel my body to fuel the work that I'm doing. Recently, as I am learning and growing and learning more about environmental justice and racism, have transitioned to a plant-based diet. And me being an all or none person went from like not cooking at all to now I grow my own vegetables in my home. Other things that I would encourage us to do as we think about kind of wellness beyond the surface, thinking about ways that we can move our bodies, thinking about ways in which we can reject the grind culture and normalize good sleep routines as a strategy for wellness. And then I can't emphasize enough the importance of community and friendships and having friends that not only just bring good vibes only, but friends that welcome all vibes and allow you to express your full spectrum of human emotion. I'm currently in the process of reading this book. It's taken me months to read it because it's making me rethink like my entire existence and how I do things. But it's focusing on decolonizing the body, providing body-centered practices for women of color to retain confidence, dignity, and self-worth. And so many of you, regardless of what your background is, may find that you actually have a colonized body. So characteristics of a colonized body includes a body that doesn't know how to rest, one that has difficulty saying no, one that feels guilty taking up space, one that feels more comfortable putting others ahead of itself, suspects that it can't rely on anyone, finds it difficult to ask for and receive support, believes it always has to be in service, useful, and working for others, and prioritizes getting ahead over self-care. And growing up in academic medicine, these are all practices that like I could replace like a colonized body with an academic physician, because these are things that we are taught how to do. And so I'm in the process of trying to unteach myself and not feel shame for having needs and prioritizing my needs and recognizing that if I drop dead tomorrow, that it's not going to help to positively impact my community. Other important things are really focusing on trauma healing. So for me, I do that through therapy and journaling and meditation and ancestral work. Self-care for me also includes inner child healing. And so one example for me is that I recently bought this wonderful, amazing tricycle, which I decorated with flowers, and which you may or may not notice from here is that I put a bubble machine inside of the basket. And so I just like ride around my neighborhood with bubbles coming out and children chasing me around. And this is a part of my self-care and my inner child healing. And because I realized how ridiculous I look on a recumbent tricycle, I decided to just lean into the ridiculous even more and put a unicorn horn on my helmet and a giant flag just to kind of lean into the ridiculousness. Self-care for me also includes remembering my why. I'm sorry. This is where we're off cycle a little bit. Self-care also includes giving myself compassion and the opportunity to grow. And I also try to extend that courtesy to others. As well as staying connected and remembering my why. So for me, my why is all these little brown babies and children and adolescents in this country. So I do this work because I know that they're magical, but I also know that they're real and that their pain is real. So I really work to try to bring a voice to their issues and reduce their suffering. And I know that their dreams are real. So I work to fight and dismantle the structures that try to limit their opportunities to achieve them. And then finally, for me, self-care is really focusing on also just purging negativity and releasing all of the things that do not serve me. So I'll leave you with this. So there is this book called Why Zebras Don't Get Ulcers. And it's based on the premise that like when zebras are out on the savannah, grazing grass and doing their thing, they do face real legitimate life stressors, including sometimes lions attacking them. And so they have these videos on National Geographics of like the zebra all running from the lions. And then one of the zebra gets got, right? And now the lioness can feed her pride, but all the other zebra that didn't get caught are now safe. And so there are videos of them just shaking to shake off all of that excess adrenaline. And then they just go on to grazing grass as if nothing happened. So I created this zebra zen room in my home to help provide a reminder for me. There's that lion that's trying to attack me sometime. And that's me and my squad running from the lion. But then how do I have a space to just shake it off and release it? And so every day when I come into my house and sometimes in between meetings, I go into this mud room and I try to shake it off so that I can move on to the next day. So with that, I'm going to go ahead and end this presentation just so that I can open it up to a few minutes of questions from you guys.
That was so amazing. Thank you so much, Tiffany. Just like I can now imagine you rolling around your neighborhood with your tricycle, unicorn, rainbow. I just want everyone on the call to know that is exactly how she comes to shift.
Yes.
Not with a physical tricycle, but with the same like loving energy that just really lights up literally any room and the darkest of emergency departments. And I'm so glad you were able to share that same light in our Zoom room. So thank you for joining us. Usually I get to use my moderator privilege and just ask all the questions that I want to know the answers to while people are posting their questions, but there are a ton of questions that I'm hoping we can get through at least a few. It seems like a lot of people were really interested in, some of your advice on self-care. I'm gonna post these up so you can see the actual questions, but I really liked this one question. It's interesting how you highlight the self-care we need. It's the type of self-care is used to marginalize us in the profession. How do we reconcile that self-care with professional self-preservation? How do we start taking collective action to address this?
So thank you so much for that question, Dr. Rose, in the chat. I will say one of the things that I am working on doing is I am working on having less F's to give. Unfortunately, I just have so many F's to give. I just give them all away freely and liberally to everyone. And as I get older, and maybe it's because I've, gotten tenure now and I can't get fired, although I still need to get promoted to full professor, I'm really focusing on how do I do the work that's important to me, right? And if you do what's important to you, for most of us, none of us have gotten to this phase in our career because we're underachievers. And so focusing on like the quality of work that satisfies me instead of chasing after grants and chasing after publications to meet these narrowly defined metrics. And then like seeing what happens. And if it means I'm not successful, I've come to the point where I'm like, I'm okay with that, right? And so, I spent so much of my career, and I'm still like actively trying to decolonize myself, right? But I spent so much of my career feeling like and seeing the reality of the need to work twice as hard to get half as far, and doing all these things to uphold these institutions that really need to be dismantled. So I'm just in my era now where I'm doing the best that I can do to try to dismantle those systems, to do amazing work that's going to positively impact my community. I use all my strategies to try to translate my work into language that my institution understands. But just, realizing that again, like if I die doing this work, then I'm not going to have the impact that I need to have. So how do I have less F's to give about these institutions and just do what's great, and then just try to translate it in ways that they can understand. But I think it also means that we need those who are in leadership positions, right, to start, instead of having these myopic definitions of meritorious, to also have more holistic views of faculty. So I would say that is the next level of challenging any of you who are in leadership roles, who help to make rules for P&T committees, to be able to expand these definitions in order to help promote success and survival.
That's great. Thank you for that. This other question, I think, is kind of the other side of what you just said, which is any words of advice for people living in states that have legislator explicitly attacking DEI efforts in higher education?
My advice is that we all need to leave and start our own country. But until we're able to do that, again, similar to me saying, like, how do I do what's important to me and translate it into a way that my institution understands instead of just doing what the institution wants me to do? For this, it's how do you do what you want to do, but then code switch and change the language, right? So when I think about my ancestors, right, they would weave quilts and put hidden messages and codes in it to translate the language. And that's what we need to do on our work. So continue to do your DEI work, but call it something different. So Adia Spinks Franklin, who I talked about in my presentation, she speaks often about how you take what you do in your job descriptions, take all the words that are in these in legislation that says you can't do it, and find synonyms for the words that you're doing, so that you can still do it, but you are, technically not violating the explicit legislature. So it's about code switching and doing things a little bit more covertly in those states that had this legislation. And then also the power of policy and the power of your votes, right? And how do we mobilize so that we can overthrow these governments that are causing harm in our community as well?
That was a great answer. Thank you. You mentioned in a lot of in your remarks, the certain inequities that we perpetuate within our own healthcare systems. But I know a lot of your work and your focus also looks at other systems and institutions, and either how their racism or discrimination directly affects our patients, or how we allow it to passively. And I'm wondering, within pediatrics, what some of the focus or the perpetrators are, and if there's being anything done kind of to combat it, either at an institutional level or now that you're, president-elect of a major academic organization.
So thanks for that question. So I definitely focused on like, what is this multi-pronged approach, right? So I spent a lot of my early career generating the data to show why we need to make the changes. And I'm now in a phase where we're working on making changes. So as I actually am now like officially president of the APA, I gave you that bio a while ago. I had my first meeting last Friday. And it's interesting because like the executive director staff person had made an agenda for my meeting. And I was like, this is my meeting and I'm about to co-opt this agenda. And they were not very happy with me about it. But we started off with the discussion on our organization actually went through a strategic planning process recently that included lots of lip service to diversity and equity and inclusion as like foundational principles, as well as strategic actions to take. And so I spent a lot of time, during that last meeting to start laying the groundwork so that people over the summertime can start doing some preparation. So the APA focuses on the professional development of pediatrics, and we had major pillars like all academic medicine, right? So those pillars are research, medical education, patient care and quality improvement things, as well as policy. And then we recently developed a DEI pillar, but then also are ensuring that the work of diversity, equity, and inclusion is foundational for the organization. So challenging those who are leading the research initiatives. What are we doing as a research pillar to help make sure that we are dismantling these systems, right? And making sure that we are making it more developing diverse scholars, helping to advance equity related research and making it more inclusive and doing that for each of the pillars. Another activities that we are going to work towards doing is for those of us who are in academic medicine and going up for tenure and promotion, there are typical kind of templates for research portfolios. In the past 10 to 20 years, they've developed education portfolios to mirror that so that people who are doing med ed work can get promoted. And then more recently, in the past couple of years, they've developed advocacy portfolios to help people who are doing advocacy work get promoted. So our goal is to next develop a DEI portfolio so that this work, and again, this goes back to that first question, do the work you love. Do the work that is positively impacting your community, that's fueling you and making you feel good. And then how do you develop tools to translate that into ways that can then get you promoted? And then I'm also trying to form some strategic partnerships with other organizations like AMSPDEC, which is the pediatric program chairs, to say like, hey, as we're developing these tools, how can you help us to do it in a way where our faculty can get promoted for doing this really important work? So that's work I'm doing with the APA. I'm also very involved in the American Academy of Pediatrics. So I spent a lot of time today talking about race-based medicine. The Academy, I'm a co-author on a policy statement that we wrote a year or two ago on eliminating race-based medicine. And we now have some grant-funded work where we're reviewing every AAP policy with an equity lens to make sure that we are redeveloping policies that are inappropriately including race and ethnicity, but also taking more of a race conscious approach to what we're doing, as opposed to the colorblind approach that has been taken in the past. So those are some of the ways that I'm leveraging kind of academic medicine platforms, while I'm also simultaneously trying to tear them down at the same time.
And you're the right person for the job. Unfortunately, we are at time. We have so many questions that went unanswered, but just a really big thank you again for coming to speak with us virtually and sharing your wisdom, knowledge, and really passion for this really important topic. So thank you so much. And thanks everyone for joining us. This recording will be on our IHER website at a later time, and we will have information on the next lecture soon. Thanks for joining and have a great afternoon.